All right, you're good.
Okay, good morning and welcome to the Insurance and Pharmaceutical Subcommittee of the Health and Government Operations Committee. I am truly grateful for everyone's willingness and dedication to be here at this hour in the morning, knowing that we have a full day ahead of us and ready to listen on some very challenging topics. We have three bills today. We have a hard stop at 9:30. I'm going to try to get through them as I can. And we are going to start with House Bill. Oh, before I do that, I would like to welcome our newest delegate to the Insurance and Pharmaceuticals Subcommittee, Delegate Kim Ross from District 8. So, Delegate Ross, welcome to the subcommittee.
Thank you, Madam Chair. Glad to be here.
Thank you. All right, we are on House Bill 1069. Life and health insurance policies, annuity contracts, discretionary clauses, prohibition. This is Delegate Warman's. Lisa, will you tell us what the bill does?
The bill prohibits carriers from selling, delivering, or issuing a health insurance policy, a life insurance policy, or an annuity contract that contains a clause that purports to reserve sole discretion to the carrier to interpret the terms of the policy or to provide standards of interpretation or review that are inconsistent with the laws of the state. And I apologize, I was tired. It actually does have an amendment that I distributed at the last minute, a reprint of it, and the amendment adds HMOs to the provisions of the bill.
Okay, is Delegate Warman here? I don't see her. So is there, can I have, here's Delegate Warman.
Move the amendment.
Thank you.
Second.
I have a motion and a second on the amendment to Delegate Warman's bill. Delegate Warman, would you like to speak to your bill? Not seeing her.
Hello.
Oh, there we go. Okay. Would you like to say anything on your bill before we vote on the amendments?
No, I just wanted to thank you guys for the hard work that you guys are doing. I know it's very bright and early, and let's start with Jocelyn Pena-Melnick. Delegate Jocelyn Pena-Melnick started a few years ago.
Okay, so thank you for the bill, and I've got a motion on the amendment and a second. Those in favor, please say aye.
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 Any opposed to the
Aye.
amendment?
Kaiser, aye.
Pardon?
Which one?
I'm
aye.
Aye. Any opposition to the amendment? Seeing none, amendment passes unanimously. Can I have a motion on the bill as amended?
Move the bill as amended.
Second.
Okay, a motion on the bill as amended. Any discussion on the bill as amended? Okay, seeing none, we are, all those in favor, please say aye.
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 Any opposition to the bill as amended? Seeing none, the bill passes unanimously. We are going to skip 1, 2, 4, 3 for now, and let's go to a discussion on House Bill 1246, Health Benefit Plans Calculation of Cost Sharing Contribution. Lisa, tell us about the bill and its amendments.
When calculating an insured or enrollee's cost-sharing contributions, this bill requires certain carriers, including those that provide prescription drug coverage through a pharmacy benefits manager, to include any discount, financial assistance payment, product voucher, or other out-of-pocket expense made by or on behalf of the insured or enrollee for prescription drugs as specified. A person that provides such a discount, financial assistance payment, product voucher, or other out-of-pocket expense made by or on behalf of the insured or enrollee must notify the insured or enrollee of the maximum dollar amount of and the expiration date for the assistance. Failure to comply with this requirement is a violation of the Maryland Consumer Protection Act. There were amendments that were distributed that require any discount, financial assistance payment, product voucher, or other out-of-pocket expense to be offered for the duration of the plan year And the amendments also prohibit a carrier from setting, altering, implementing, or conditioning the terms of health benefit plan coverage, including the benefit design, based on information about the availability or amount of financial or product assistance available for a prescription drug or biological product.
Okay, so I'm going to explain these amendments, but then I'm going to open it to discussion. And I see that someone has that Mike Johansson has his hand up, but I just want to explain to those who are watching that these two bills are balancing between what the pharmaceutical manufacturer does and what the pharmacy benefit manager does, in terms of making sure that the benefit to the participant, to the person who's actually purchasing the drug at the counter, has the maximum benefit of the assistance program throughout an entire plan year, so that there's no cliff and there's no expectation, unexpected, not expectation, unexpected increases in their drug cost for that particular drug. So with that, I'm going to open it to discussion, and I'm going to go to committee members first. So Delegate Kipke.
Thank you, Madam Chairman. And I'll just restate that, I supported this approach in the past, but I had an epiphany because I paid enough attention to it to have respectfully disagree with our approach, which I hate to do, honestly, Delegate Collison. I hate doing it, and
It's fine, Delegate Kipke.
All right. I believe these discounts. So first of all, this does not apply to Medicaid. So for people on Medicaid, which is a big chunk of Maryland, this doesn't matter to them because they're covered. This, I believe, is a bill that seeks to help people in the middle class who have high deductible health insurance policies through their private, small business employment, basically. So people who have individual, small group benefits through their small employer, most of them, I would venture to say, have a high deductible plan. Basically, $2,000 of health costs come out of your pocket before the insured policy kicks in, and that's to mitigate the cost of the premiums. So if you are going to end up needing a costly treatment, which God forbid any of us need, but many people do, some life-saving thing that costs $20,000 a month, whatever it is, the pharmaceuticals use a tool to discount that product, basically to cover the out-of-pocket expense for high deductible plans. So they'll give you the thousands of dollars of discounts for a limited period of time that they have actuarially. I'm sure some really smart bean counters have figured that out to cover the out-of-pocket cost of high deductible plans, and that's a benefit to the consumer, and something I know we all support. What we're saying is that coupon with this bill, that coupon or that discount should apply to the deductible. It shouldn't. Right now, some of these unscrupulous insurance companies and PBMs are not counting that discount, and so that's what we're trying to remedy. I think that's the big picture. We're trying to remedy that. The amendment that seeks to extend that discount for an entire policy year, I think, is something that the insurers and the PBMs are pushing for as a way to kill the bill, because first of all, the Senate doesn't like it. Hasn't passed in the past in this format. Maybe it will this year, but I think that's a benefit. That amendment that requires it to be a whole year, that's the insurers and PBMs saying we want more money. This is all about money, and in the middle of it is the consumer, which I know that the chairman, my beloved friend, is trying to help, and I support that. So I don't think passing the bill with a 12-month requirement is helpful in this situation. I think it's harmful. It will prevent the consumer from being aided. by passing it, you're not helping the consumer. I mean, you're helping rich consumers maybe, but you're not helping the people that we all want to help. Because those people are on the high deductible plans. If they're uninsured, that's a whole other story, and they can't afford it anyway, unless they're rich. Those are my thoughts. I submit them respectfully. I want to help the same people that I know we all want to help here, but I think being aligned with the insurers and PBMs on this amendment, I think, is harmful to getting that help to the consumer and does nothing but serve their own profits. Thank you.
Yeah, thank you. I truly appreciate your insights, Delegate Kipke. I'm going to go to Delegate Johnson.
Thank you, Madam Chair. The whole purpose for the notice and covering for the whole plan year is people that are on fixed income, that have limited income, that cannot go out and get a loan, they don't have the money. For them to be able to manage their health care throughout the year. They need to know what it's going to cost. They need to know the consistency. That was the reason for the notice and for the full plan year. So they didn't get into their plan year and then the rug was pulled out from under them. I respect Delegate Kipke because I know he definitely thinks about the best interest of Marylanders. However, after working on this bill for a long time, we don't want to leave somebody vulnerable to have the rug pulled out from under them, and that was the whole premise behind the amendments. And the manufacturers, make no mistake, these discount coupons and rebates, they are a marketing tool. They're not spending $170 billion a year for nothing or just to help the consumers. It's definitely a win for them as well. So with that, I'm going to turn it back over to the committee. Thank you, Madam Chair.
Thank you, Delegate. Okay, I saw Mike Johansson among the non-committee members first.
Madam Chair, if I can defer, because I was going to ask a clarification question, not exactly on this issue, and I think others may want to talk specifically here.
Okay, great. Just keep your hand up. Lance Kirkpatrick?
Yes. Thank you, Madam Chair. In talking with my national folks around the language around full duration of the full plan year, right? A couple scenarios were raised to me that I didn't have answers for, so I'm hoping to get some clarity from you on those. So the first scenario is where a person has a $6,000 deductible health insurance plan and they're eligible to receive $6,000 in copay assistance. Assuming that would be split up in monthly payments, that would mean that an individual gets $500 in copay assistance. They would not reach their deductible until the end of the plan year. But say they have comorbidities or they have a family plan that has medical needs, right? Their son breaks his wrist playing basketball. The spouse has to get carpal tunnel surgery. If the copay is paid out at the beginning of the plan year, then none of those situations have to be paid out of pocket because the deductible has been reached. But by extending the copay assistance out over the full plan year, more out-of-pocket payments have to be made by that individual. And frankly, I'm not sure where the later assistance payments go to in the end in this situation. And I couldn't explain how this ultimately ends up not causing patients to pay more. So that's scenario number one. Scenario number two, I think, is a little more straightforward. If I get a new job in June and the copay assistance I receive is spread out over the full plan year, does that mean that I only get half of the assistance because I'm only in the plan for half a year? Because clearly the deductible is not going to be halved. So I'm hoping I can get some clarity on these two things, especially the first one.
So with respect to the first one, that presumes that the amount of the copay assistance is upfront. I'm not making that assumption. If that is the truth, then someone is going to need to tell me that. But my assumption has been that the copay assistance happens at the point of sale. And if it happens at the point of sale, then it's each time the person is going to buy that drug. So there isn't a $6,000 payment upfront to anyone. It is simply a lower price of the drug at the point of sale, which if the person's copay on the drug which is what we're saying would be with this bill applied to the person's deductible. So with a $6,000 deductible, they would meet the deductible after 6 months. So that's my answer to the first one. To the second one, it presumes that the money is given up front. If you start the program in June, then the assistance program in June, it would go until December with renewable, because the notice form says it can be renewed for the following plan year. So that's my response to the second one.
And ma'am, I have to say, and I know Mr. Prentice and others can speak to this more eloquently, but a lot of my folks in my constituency, yeah, they get a full shot up front.
If they're getting a full shot up front, couldn't that then pay the entire deductible at that moment?
Yeah, I'm just not sure based upon
Right.
this language. I'm not sure how you see what I mean when you put it over the full duration. That's where it gets confusing is in terms of what that definition actually is.
Right. Well, that goes to the part from my perspective to the Second Amendment around the payers not being able to change the plan. So it seems to me that would be a change in the plan if somehow with money that's not real money, because it's really just a reduction in the price, right? That they're not getting that money, and then and applying it and not applying it to the deductible. So the bill is designed to apply whatever copay or whatever assistance to the price of the drug and to cover the copay or the deductible. All right, I'm going to go to Matt Prentice.
Good morning, Madam Chair and subcommittee members. So I'm talking on behalf of the coalition. So I'll kind of start nice for first. You know, we really want to support and we really thank you for your support for the Second Amendment. I just want to emphasize that this is really important language, a step in the right direction. I really think it makes Maryland a trendsetter in not only addressing copay accumulators, but all these other policies and programs that have popped up that we believe negatively impacts access to financial assistance. And so I want to get that out of the way. On the Second Amendment, you know, I've been working with several patient groups over the last 2 days and the non-manufacturer charitable organizations that provide millions in financial assistance for out-of-pocket costs a year. And I think they're just trying to wrap around how this would be operationalized, because I'm not aware of this kind of requirement in any other state. The notification requirements, I know we have precedent in Maine, and I think we've talked a lot and have built a lot of compromise around what should be told to a patient. But this new amendment really, it will drive how copay assistance is provided to individuals. And my understanding is the first time in the country I've seen that. And so what I want to echo is just Lance's comments in that, you know, copay assistance is to provide individuals with the support they need when they need it and for it to contribute towards their out-of-pocket costs. And so I, again, am concerned about this idea that, like Megan Waring, who provided testimony last year, her son has a bleeding disorder. She received thousands in copay assistance in the beginning of her plan year. The treatment her son receives is on such a high cost-sharing tier that those thousands were spent in the beginning of the year for her to meet her deductible. Of course, she's on an accumulator, so it didn't. But I'm trying to imagine with this new legal requirement, would that manufacturer or charitable assistance fund, instead of giving her the money she needs for that high cost sharing amount in the beginning of the plan year, would they spread it out through the rest of the year? Because on a health plan, it's not really about like how much money you have throughout the year, at least for the chronic and rare disease community. It's about how soon you can meet the deductible, right? Like in January, I'm doing an assessment of like how much money will I need to meet my deductible, right? And so in that sense, I just worry that we're delaying the assistance for individuals who would already have received it and met their deductible. And for Lance's points about comorbidities, other members of the family who have different medical needs, I struggle to see how spreading it out provides benefit if they would have already received it.
Okay. I'm going to say the same thing I said to Lance. That's presuming that it's all put up front. And also, I need to remind folks, this is not about charitable assistance. Take charitable out of the vocabulary for this discussion. It is all about manufacturers' assistance programs. Matt Celentano. Where'd you go?
Thank you, Madam Chair. I was actually just going to say the same thing. This is not a bill about charity care. It is about manufacturer copay assistance. But I wanted to see if I could try to alleviate some of Delegate Kipke's concerns. First, on the high deductible health plan language. That is language that came from the MIA last year, and it is strictly because the state of Maryland cannot preempt federal law. So that's why that language needs to be included on the copay assistance bill. Two, there is a reason that we don't have coupons in the Medicaid program.
Could you explain that further? Sorry to interrupt, but in the interest of time, could you explain that further? Because I don't understand what you just said.
We can't extend the provisions of this bill to the high deductible health plans because of federal law, which preempts it. I think I will defer to, I think Ms. Sexton is on from the MIA, but I can get back to that in a second, Delegate Kipke.
Right, so I'm going to interrupt you, Matt, for just a second. I think Delegate Kipke was not referring to the federally defined high deductible plans. I think he was more referring to, plans on the exchange that have, there are some plans that have $2,000 deductibles, or other, or people in an ERISA plan may have a $2,000 deductible. So I think that's what he was referring to. Delegate Kipke, am I correct? You were not referring to the federally defined high deductible plans, which operate very differently.
I think that these discounts on the pharmaceutical products exist for high deductible plans, which many people have. And the bill helps those people, but and I want to help them, and I want to get the bill passed. I know that the PBMs will sure don't like it. I don't want to repeat myself.
I appreciate that, Delegate Kipke, and I think why we were here and why we were at the table, FWA, on this bill. I think there is robust consumer protection in the bill that you have in front of you, the reprint, and that's why the carriers have been supportive of trying to extend these provisions to the full plan year and making sure that, like Delegate Johnson said before, that the rug doesn't get pulled out from under consumers once they have been sort of hooked. I mean, there's no doubt about it. Coupons are a marketing ploy. This is not charity care. Let's just be real about that. Two,
it kind of is charity. It kind of is charity care in that there are people in the middle class who can't afford a $2,000 hit in January, and so this, and so by applying the coupon or the discount to that, it helps those people.
We don't disagree with you, Delegate Kipke, and that's why we're supporters of this approach that you have in front of you. But I would say, as to it not helping low-income folks, there's a reason for that. And in the Medicaid program, why there isn't coupons, and there's not coupons in the Medicaid or Medicare program, and that's because the Federal Trade Commission said that coupons in general are an illegal kickback. So the only place that coupons exist in the commercial market, and if we really want to have a robust conversation about what coupons and the value of coupons, I mean, maybe we should follow the lead of states like Massachusetts that have banned coupons altogether, because the price is the price. Right? The pharmaceutical manufacturer is the one setting the price, and they're the one giving the coupons. We think this is sort of a shell game, but we don't want to, if we're going to talk about coupons in this instance, in this bill forward, we want to make sure that there's a robust consumer protections. And that's why we think that it's important that there's a full plan year protection to make sure that the consumer, the ones that might be in those high deductible plans, are protected for the entire plan year. Thank you.
Thank you. Next, I see Kimberly Robinson. Kim?
Sorry, Madam Chair, working to come off mute. Apologize for not being able to be on camera this morning. But thank you for the opportunity to speak. So Kimberly Robinson for Carers Blue Cross Blue Shield. We are not a PBM. We are only an insurer. A couple of points that I would like to just reemphasize. I'll just echo what Mr. Celentano just pointed out, which is, there's some controversy around how manufacturers use coupons. There's lots of data that shows that, and actually the person I really want to echo is Delegate Johnson, who I think did a very good job about talking about what some of the tension is around coupons, right? This, respectfully to Delegate Kipke, who I'm very fond of, this is not charity care. This is actually very profitable to manufacturers. There are studies who show that basically for every dollar of coupon they give, they actually make $2. There's a reason why the federal government has deemed these to be kickbacks, because what they are really used to do is to influence drug purchasing decisions by driving people to more expensive drugs. When you layer all of our laws together, right, you move someone to a more expensive drug, you entice them in with a coupon. When the coupon goes away, our law says that person can't be asked to switch to a less expensive drug. They get to stay on that more expensive drug to not disrupt their care. But what that then does is actually pack a cost into their overall insurance. And as premiums continue to rise and are driven by the cost of drugs more than any other service, more than half of your premium dollar is covered just drugs for everyone in your plan. That is a really significant expense. And so the reason why we've worked so hard over these couple of years to find a middle ground on this bill is because we always want what's best for our members. We are the ones, we're not a PBM, we're not in that part of the negotiation. We are simply here trying to ensure that people are able to take the best advantage of their benefits and get the care that they need. And so these amendments are designed to make sure that that is what's happening, that we're managing the profit motive, that we're managing access to care, and that we're trying to do our best to manage these deductibles, which unfortunately are part of the system because of the high cost of medical care. And so with that, Madam Chair, I support the amendments and thank you for the opportunity to speak.
Thank you, Kim. Mr. Johansson, do you want to weigh in now, or are you still waiting on another?
If I could, Madam
Yes.
Chair, on page 3 of the bill, I have 2 questions about the language in D, which is the underlined amendment language. The first one is it suggests that the entity, which means the carrier, may not set a coverage, including a benefit design, based on the availability of financial or product assistance for a prescription drug. I think it's a little broad and may impact rebates that carriers or PBMs negotiate with manufacturers. I don't think that's what we're intending here. If Lisa could kind of just make sure we're not suggesting that you can't, based on a rebate where we can change things on a tier, that's a benefit design thing. I don't want that to impact that. And the second thing is the reference in that last phrase to a prescription drug or biological product. I think simply saying prescription drug is appropriate. That's all we said on page 2. We didn't have to separately reference biological product. But I'm more concerned about the impact that language would have on rebates and benefit plan design. Thank you.
Lisa, do you have thoughts on that?
We can work on the language with Mr. Johansson to come up with something that helps resolve his concerns, if that's what the committee would like.
Oh, and Mr. Johansson, would you be comfortable if we did that conceptually, if we're able to move forward on the bill?
You're the chair, Madam Chair.
Okay, just checking. Delegate Johnson.
Yes, Madam Chair. Yeah, we can continue to look at this language to make sure we get it nailed down correctly. I'm going to trust the work of the committee on that.
On what Mr. Johansson was speaking about?
Yeah, I was looking for the exact verbiage he was speaking of. Can you tell me again?
Page 3 between the lines 11 and 12.
Gotcha.
It's in the reprint. It's
yeah.
okay.
Okay. Okay.
Yeah,
Lance
we can look at the language on that.
Okay. Lance Kirkpatrick.
Thank you, Madam Chair. I just wanted to point out, I appreciate Kimberly and Matt's comments, but based upon the way the language is written in the bill at this point in time, charitable foundations that provide assistance to patients would be caught into this scenario. I'd point out the Patient Access Network Foundation, who submitted some very good written testimony regarding upon how their donations to patients that apply to them for assistance, which tends to be a lump sum payment, right, would get caught in this scenario that you're trying to put forward. And I believe there are roughly 9 foundations that provide this charitable assistance as well. It's not manufacturer assistance, right? It's charitable assistance. So in the scenario, as the way the bill is written now, it's my understanding that they get caught up in this too, which based upon the what we've been talking about, doesn't sound like the intent of the committee and the sponsor.
No. And I would ask, Lance, are you referring to page 2 where it says an insurer, a nonprofit health service plan? Are you thinking a nonprofit health service plan is a charitable organization?
So specifically, I'm just having glanced through the bill quickly, right? So, it does say a person that provides a discount financial assistance payment, product voucher, or other out-of-pocket expense made on behalf of the insured enrollee that is used for calculation, et cetera, right? It applies to. So in this case, my reading is that, financial assistance payment would loop in a charitable foundation who is making a financial assistance payment to the person who applies for that assistance.
Does a charitable foundation provide coverage through a pharmacy benefit manager? Do they buy the drugs from a pharmacy or through a pharmacy benefit manager?
I don't have enough knowledge to be able to answer that correctly, but again, my understanding and again, others on this Zoom probably have more knowledge than I do, but Lance Kilpatrick applies to the Patient Access Network Foundation for assistance, and they say, "Hey, I've got this drug. I need some help." The foundation goes through their process, just like any other foundation, right? And makes a determination as to how much, if any, assistance can be provided to them.
Oh, I'm sure that we could make sure that they are excluded. I mean, because we wouldn't want them included in this. Delegate Shalega.
Thank you, Madam Chair. Just had a question about the notification portion that's on page 3 of the reprint, starting on line 4, and it looks like it goes through line 9. Was there some other language we had talked about that was from, Maine that they use for notification that talks about notifying an enrollee with 7 days of the within 7 days of acceptance of the financial assistance, of the total amount of assistance available and the duration for which it's available?
We don't have the language from Maine. We have this language, and the notification form that I was shown is the one from Maine. So, and it could be either on paper or electronic, and that's how they're doing it in Maine. And it does give the start date, the end date, and I honestly can't remember if it gives the amount or not, but it does give the start date and end date. It must also give the amount.
I mean, it could be helpful. Again, we're rowing towards the same goal, which is helping patients with these out-of-pocket expenses. But giving the 7 days, that the notification should have some kind of time limit on it, I would think.
Okay. I believe that it does, but we'll need to circle back on that.
Okay, thank
Thank
you.
you.
And
Thanks
I
for
can
pointing that out.
provide that. I can find that if you'd like me to.
I would love you to do that.
Okay,
Thank you very much, Delegate. I appreciate
Okay.
it. Kimberly Robinson.
Thank you, Madam Chair. I just wanted to respond on the charitable entities. I think there's some misunderstanding about how this all works, right? The coupons that are the subject of this bill are the manufacturer coupons, and they are experienced by the patient at point of sale in the pharmacy. They don't really in that way operate any differently than any other manufacturer coupon you get. If you're using one to buy paper towels, it's a manufacturer coupon. You're giving it to the retailer, who is the one who is then doing all the process of discounting your purchase. They then send the coupon into the manufacturer. The manufacturer then makes them whole for the part that you didn't pay, right? When your paper towels were discounted from $8 to $6. That's where that transaction is happening. That is different than what happens with charitable care. The charitable care is not happening at the point of sale between the pharmacy and the charity. It is happening between the patient and that charity. It is opaque, frankly, to the carrier who is then paying those claims. What it's really doing is that patient is still actually paying the full freight for that purchase. And then the charity is either providing them the funds that they're using to pay it or give funds to make them back whole for what they've spent. This bill is not touching the charity care because it's not in the system that the bill is actually speaking to. So I just wanted to give some line of sight. I think there's always a lot of misunderstanding about that. Rightfully so. People don't want to lose the ability to take care of people and support people, but it's no different than, you know, when I was younger and making very little money and my mom gave me the money to go pick up my drugs. She gave me the money. My carrier was not going to know that my mom handed me the money instead of it came out of my bank account. It's much more akin to that.
Okay, thank you. Thanks for the clarification. Matt Celentano.
Thank you, Madam Chair. Just real briefly, because I know we're coming up on time, I just wanted to maybe make Mr. Kilpatrick feel a little better that this bill doesn't do anything to any sort of charitable organization or a pass-through organization for the manufacturer to get the coupon to the folks that might need to use it at the point of sale. And two, Ms. Robinson earlier mentioned the return on investment from the carriers, or not for the carriers, from the manufacturers on the coupons they provide. And she said that it was $2 for every one that they put out in coupons. It's actually not 2 to 1. I wanted to correct her. It's 20 to 1. It's a $20 million investment on every $1 million of coupons that are distributed to the public. So just for the benefit of the committee. Thank you.
Okay. So what I'm hearing is, I think there's clarity around the charitable entities, because I believe I can verify this, but I do believe that given the definition that says it applies to anyone who purchases drugs through a pharmacy benefit manager, which I doubt charitable organizations do, or would ever want to. We need to clarify the language to make sure that it does not negatively impact other programs. And we want to clarify the language around the notification, giving, appropriate notice in advance. So I am suggesting that we hold this one more time and know that we're going to talk about it next Tuesday, and hopefully all these will be worked out and we'll be ready to roll. Does anyone object to me holding this bill?
Second.
Very good. Thank you. All right, then we will do that. And I believe we're going to have a 6-minute conversation. I do not believe we're going to be able to vote on 1243 today, but let's have a brief conversation about it. And I understand that there's still some, what we might say, backroom discussions going on that I learned about this morning that I would like to continue, and perhaps we could get to some resolution. So given that, Lisa, tell us about 1246, which is, 1243, health insurance coverage for specialty drugs. Delegate Johnson.
The bill prohibits carriers, including those that provide prescription drug coverage through a pharmacy benefits manager, from excluding coverage for a covered specialty drug administered or dispensed by a provider under specified circumstances. If this prohibition applies, the reimbursement rate for a covered specialty drug must be agreed to by the carrier and the covered in-network provider and billed at a non-hospital level of care or place of service. The bill does not prohibit a carrier from refusing to authorize or approve or from denying coverage of a covered specialty drug administered or dispensed by a provider if administering or dispensing the drug fails to satisfy medical necessity criteria. The amendments that were distributed provide that the provisions of the bill do not supersede the HSC's authority to set rates for specialty drugs administered in settings regulated by HSCRC, and they prohibit the reimbursement rate for specialty drugs from exceeding the rate paid to a designated specialty pharmacy.
Okay. So again, I want to do a little bit of background on these amendments. First, the one related to the Health Services Cost Review Commission is basically saying this doesn't apply to hospitals. The other amendment regarding the reimbursement rate is recognizing that what the physicians in this that are asking to do this are doing are essentially becoming the purchaser of drugs, and as in the same way that a pharmacist does. And so this this amendment about the reimbursement rate is saying basically they will be behaving like all other pharmacies, purchasing the drugs at the best price they can find, and then being reimbursed at the rate that is negotiated by the payer or the insurance company. And that what we're saying with this is that the negotiation can't result in them being paid back at a higher rate than what they would have paid their specialty pharmacy. So I think that is the area of the lack of agreement. So let's have a very brief discussion. I know that Caitlin is here, Caitlin McDonough, and I think I think Zach Peters is here, Kim Robinson, who can speak to it as well. So if you would just speak to your position, and then we're going to need to go because I've got to get to another meeting. But so I'm going to start with Caitlin McDonough.
Thank you, Madam Chair, and good morning, committee. And this is a bit of a point of contention to us. We do believe that the bill as introduced, where would both the carrier and the PBM and then the dispensing provider would have to come to an agreement on a rate, gives ample ability to the carrier to control that rate and likely keep it at the same rate that they're paying other in-network providers. I think our concern with this ceiling or cap language is that is presupposing the outcome of a future negotiation in statute, which may not necessarily have a major numerical practical impact on the outcome of these negotiations, but we think it sets a pretty dangerous precedent where, you know, carriers and PBMs can cap negotiations in law before a provider or they even get to the table. That is concerning to us. I will note, and honestly, this is happening in real time this morning while you've been talking about accumulators. I think we are looking at some other areas of law, and Dana may be able to help me since MedCog was a little more deeply involved in these negotiations where the legislation that's passed around value-based care in the state does put some parameters around those negotiations in law, but it empowers both sides to kind of take cost savings considerations, which there are ample in the other provisions of the bill that Lisa listed, take those cost savings into consideration in that negotiation, and they could potentially exceed that cap if both sides agree and they're kind of recognizing that those savings are offsetting any additional cost. Would not necessarily happen. It just gives a little bit of flexibility. I'll be honest, I'm still kind of negotiating that out with the physicians and some of the folks on our side, but it is something I kind of wanted to put out for discussion. And I will also note the carriers have not had a conversation with them about that. So this may be a new suggestion, but because it is something they've agreed to elsewhere in Maryland law in a similar situation where there are cost saving parameters laid out in the bill, it's something we'd want to discuss. And I'm sure Dana can provide additional details on that, but you know, that's our issue, and that's kind of where we're maybe headed.
Okay, great, thanks. All right, so I'm in on a time crunch here, so I'm going to go. Dana, could you briefly describe what you're recommending or thinking about?
Sure. So in a value-based bill, if you look at, and I'm just going to throw out the site so everybody can take a look at it. If you look at insurance 15-113 F2 and F4, there were parameters put around the negotiations, but they were qualified to basically say, and we did this for the carriers, that says unless mutually agreed to by the carrier and eligible provider. And those were in two different sections. So I think the thought here is you could put the same qualifier, that unless mutually agreed upon. So it still does allow the ability for negotiations. But again, it is a agreement that has to be made. And again, we did that for the carriers in the value-based bill. So that was one of our thoughts. But it literally came up like a half an hour ago.
Because it just occurs to you automatically.
It kind of did.
It's always working, Dana. Zach Peters.
Good morning, Madam Chair, members of the subcommittee. I'm not familiar with that language, so Dana and Caitlin, we're happy to look at that. I think on the cap language, the biggest concern that we would have is just making sure that no one pays more. That's really the goal, and not necessarily predisposing any type of negotiation. So we're happy to keep working on this.
Thank you, Zach. Kimberly Robinson.
Thank you, Madam Chair. You have to go, so I'm going to say this as quickly as possible, and we'll take the conversation offline. I don't know that there's anything materially different about what was just mentioned from the value-based care law. Agreed upon is agreed upon, and of course, it's mutually agreed upon. This is not intended in any way to be a one-sided provision at all. I think the importance of the cap is to say Maryland has very intentionally created its specialty drug law for how it's covered under insurance, understanding that, again, drugs drive the cost of health insurance more than anything else in the state, in the country, and that these are the drugs that drive it. The goal with this bill, and the reason we have been cooperating on it and working on it for so many years, is always been on the premise that the goal is not to raise the cost of drugs. And so the language as the bill is currently crafted is intended to say there is a ceiling. And if you pass by that ceiling, you are in fact going to raise the cost. And that is why, for me, again, a company who is not a PBM, we are only looking at how we manage the cost ultimately of health insurance. This is an incredibly, incredibly important feature of this bill. Without the ability to keep that cost down, this is going to simply increase costs to this discrete set of patients who are already experiencing very, very high costs. They are the ones who are going to meet their deductibles, and we have significant concerns if that were to go away. So thank you, Madam Chair.
I'm going to take Matt Tolentano, and then we do have to stop. Obviously, the conversation needs to continue. The bill will be held because a number of our members need to be in another committee now. So, Matt, did you want to briefly say something?
Try to be brief, and there is nobody more than me that wants this bill to be done and go away after 7 years of doing this. But I think we're still stuck at the same point, right? And I think Ms. Robinson alluded to it, but the high cost of drugs, and especially specialty drugs, is the biggest concern from the carrier's perspective, and why we want to make sure that these drugs don't get marked up another time, that they are flat and they don't expose the consumers to more spending. In 2023, more than 65% of prescription drug spending occurred in 2% of prescriptions. That is these types of drugs. They're incredibly expensive. And we want to make sure that the consumers are protected. In states that have medically integrated dispensing in the hospitals, if they don't have that cap on the price, in hospital settings, we're seeing 400% markup. In medical practices, physicians kind of dispensing, we're seeing at least 25% markup. So there are other states doing this, but without the cap, it's dangerous for the consumer. And we want to make sure that we make them whole and protected. Thank you very much.
So that's the final word for today. We will discuss this. Please watch your emails in terms of when we can schedule another meeting. And I appreciate the discussion this morning. A good example of how we do our work in subcommittee. With that, this meeting is adjourned, and have a great